All right, let's dive right into this explainer. It's all fun and games until we start talking about a heart that's literally starving for oxygen. Welcome to our high-energy whiteboard breakdown of anti-anginal drugs, where we're going to make pharmacology make perfect sense. Today, we're grabbing our virtual dry erase markers, and we are mapping out exactly how to save the heart from ischemia. Let's get to it. So here's a quick question to really kick us off. What is the most dangerous thing about that sudden, heavy, crushing chest pain? Well, it isn't just the pain itself, right? It's the underlying oxygen starvation. Without oxygen, your myocardial cells, which are the literal engine of your body, are suffocating. They're dying, and we need to act fast before they're gone for good. Now, if you've ever felt like a totally confused neuron trying to memorize endless lists of side effects and pathways, don't even worry about it. We're going to clear that fog right now. I'm going to show you how to learn, understand, and actually remember these tedious medical pathways. So no more blankly staring at thick textbooks. We're going to map this out together on the board.
Okay, let's draw this out. On one side, let's use cool blue, we have your myocardial oxygen supply. That's the blood flowing through your coronary arteries. On the other side, in sharp red, is the myocardial oxygen demand. That's how hard the heart is actually working. Angina pectoris is simply a life-threatening imbalance between these two. It's a battle. Everything is perfectly fine until your heart suddenly demands way more oxygen than your clogged atherosclerotic arteries can actually supply.
So here's our battle plan for today. We're covering the types of angina, the anti-anginal classes, beta blockers, calcium channel blockers, nitrates, and sodium blockers. And then we'll wrap it all up with the treatment algorithm.
All right, Section 1, Types of Angina, Knowing the Enemy.
Watch as I quickly chart this out for you. First up, we've got stable angina. This is effort-induced, like you run for the bus and boom, your chest hurts. You sit down to rest or you take nitroglycerin and it's relieved. Very predictable. Next is unstable angina. Now, this is the really scary one. It happens at rest, it's an acute, crescendo emergency, and it is not relieved easily. Finally, we have Prinzmetal, or variant angina. This one's kind of the oddball. It's caused by a sudden vasospasm of the coronary artery at rest. It's completely unrelated to exercise, but the good news is it responds beautifully to vasodilators. Moving on to Section 2. The anti-anginal classes, our pharmacological arsenal. We basically have 4 hero classes to cover today. We've got beta blockers, calcium channel blockers, organic nitrates, and our backup player, the sodium channel blockers. Make sure you keep this mental map really handy. Section 3, beta blockers, slowing the engine. Okay, if you want a really quick mnemonic to write down on the board here, beta blockers block the beating. Let's highlight metoprolol and atenolol in bright blue. These are our selective beta-1 antagonists. By targeting just the beta-1 receptors right on the heart, they brilliantly reduce the heart rate, they lower contractility, and they drop blood pressure. Basically, they're just telling the heart to chill out and stop working so hard, which massively drops that myocardial oxygen demand. But remember, every single drug has a trade-off. Let's write out these side effects. Since they slow the heart, naturally they can cause bradycardia and fatigue. So you never use them in a patient who already has severe bradycardia. Make sense? Now, if you use non-selective beta blockers, you risk blocking beta-2 receptors, which causes bronchoconstriction, so definitely keep those away from your asthma patients. And here is the real kicker. Prescribing beta blockers for Prinzmetal vasospastic angina? That is a total doofus move. Seriously, they are completely ineffective for that, and they can actually worsen the vasospasm. All right, Section 4, calcium channel blockers, the pipeline managers. Now, grab a red marker for this massive memory hook. Amlodipine acts on arteries. The dihydropyridines, like amlodipine and nifedipine, act mainly as these really powerful peripheral vasodilators. They just open those vessels right up. On the flip side, the non-dihydropyridines, which are verapamil and diltiazem, well, they act primarily right on the heart tissue to slow conduction and contractility. It's just a brilliant contrast in how these two subclasses actually function. Let's jot down some side effects for these. Verapamil has a pretty notorious reputation for causing constipation. Honestly, it basically just backs up your bowels. It can also exacerbate heart failure because of its negative inotropic effects. Then you've got amlodipine. Because it dilates those peripheral vessels so well, it often causes peripheral edema, swollen ankles, and facial flushing. And I'm going to draw a huge caution sign right here on the board. You must avoid both of these classes in patients with an existing AV block. Moving to Section 5, nitrates and sodium blockers, the heavy hitters. Let's trace the actual chemistry on the board here. So nitroglycerin enters the body and converts into nitric oxide. This activates CGMP, which leads to this massive relaxation of the vascular smooth muscle. And this brilliantly illustrates our main mechanism, which is massive venodilation. By dilating the large veins, we drastically reduce the preload. That's the volume of blood returning to the heart. And think about it. Less blood returning means less blood to pump, which means the heart simply doesn't have to work as hard. Now, I need you to put a giant warning sign next to this one. Never, and I mean literally never, mix nitrates with PDE5 inhibitors like sildenafil, because both of these drugs powerfully dilate blood vessels, right? So if you combine them, they're going to cause a profound, unsafe, and potentially deadly drop in blood pressure. Seriously, keep them far, far apart. But what if all of that still just isn't enough? Well, enter ranolazine. This is our sodium channel blocker. Think of it as the backup player you call in for chronic stable angina when the standard therapies just aren't cutting it. And the cool thing is, it works without significantly affecting the heart rate or blood pressure. But of course, there's no free lunch in pharmacology, right? Quick side effects to list out, we've got constipation and dizziness, but the really sharp warning that I am circling in red on the whiteboard right now is QT interval prolongation. You absolutely have to monitor the patient's EKG because prolonging that QT interval can lead to some really dangerous arrhythmias. And finally, section 6, the treatment algorithm, putting it all together. So here's the step-by-step clinical logic. Step 1, lifestyle changes and guideline-directed therapy. Manage the blood pressure, fix the diet. Step 2, hand them sublingual nitroglycerin for immediate relief during an acute attack. Step 3, you put them on a beta blocker as your first-line preventative defense. Step 4, if they're still having angina, that's when you add a calcium channel blocker or a long-acting nitrate. And finally, step 5, if the relief is still totally inadequate, that's when you bring in ranolazine. To wrap this all up, I want to leave you with one final thought. Imagine your patient is sitting right in front of you, they're clutching their chest, and their heart is starving for oxygen right at this very second. Which weapon, from everything we just wrote on the board, do you reach for first? That's right, sublingual nitroglycerin to instantly drop that preload. If you keep these pathways mapped out in your mind, just like we did today, you'll absolutely conquer this topic. Thanks so much for learning with me today.